Hello and welcome to another edition of Multiple Sclerosis Highlight Report, our webcast series. And today I will be reporting on some interesting abstracts from the ECTRIMS 2016 meeting in London. I'm Devon Conway, a staff neurologist at Cleveland Clinic's Mellen Center for Multiple Sclerosis. And we'll be talking primarily about advances in management for multiple sclerosis. The first abstract that I wanted to highlight received a lot of buzz at the conference and was called Efficacy and Safety of Sapana in Secondary Progressive MS. These results are from the EXPAND study. So Sapana is a selective S1P receptor modulator. So it's similar to fingolimod, except that it more selectively targets the S1P1 and S1P5 receptors. And because of this, the thought is that it's less likely to cause complications such as bradycardia, which we see with fingolimod. So with Sapana, for instance, we can mitigate the bradycardia issue with a dose titration scheme as opposed to having to do the 6-hour first dose observation that we do with fingolimod. To be included in this study, patients had to be 18 to 60 years old, and they had to have a history of relapsing MS, but they had to be relapse-free for 6 months with an EDSS between 3 and 6.5, and they had to have had progression over the last 2 years with either a 1-point increase in the EDSS if they were less than 6, or a 0.5 point increase if they were over 6 in those prior 2 years. The primary endpoint in the study was time to 3-month confirmed disability progression, and patients were randomized in a 2-to-1 fashion to receive either Sapana, which was about 1,100 patients, or placebo, which was about 550 patients. In terms of their baseline population, the average age was about 48, with an average disease duration of 16.7 years and an average EDSS of 5.4. So we were looking at a fairly advanced population here. In terms of surveying the population for evidence of inflammatory disease, about 36% of them had had a relapse in the last 2 years, and about 21% had a gadolinium-enhancing lesion on their baseline MRI. Now moving on to the results, the primary endpoint, which was time to 3-month confirmed disability progression, the hazard ratio was 0.79 for patients receiving Sapana. So that translates to a 21% risk reduction for 3-month confirmed disability progression, and that was a significant result. Notably, however, when they did subgroup analyses of the primary endpoint, the confidence intervals in those groups that appeared less inflammatory tended to cross 1. And what I'm referring to are patients who did not have relapses in the 2 years before the study started, no gadolinium enhancement on their baseline MRI, or who had had a longer duration of disease. So those patients did not seem to have a significant benefit based on these predefined subgroup analyses. The secondary endpoint, time to 6-month confirmed disability progression, also favored Sapana with a 26% risk reduction, which was significant. And adverse events were similar between the groups, including cardiac disorders and ocular disorders, which, as you know, we are concerned about with fingolimod therapy. So these results are definitely very exciting, but I think we do need to interpret them with caution. The subgroup analyses suggest that the drug was most effective in patients with ongoing inflammatory disease. So this might be similar to what we saw with the beta interferon studies, in which populations that had more inflammatory disease seemed more likely to benefit than populations that were purely progressive. So it might be interesting if a trial with patients who had purely progressive MS, and what I would mean would be no relapses, no gadolinium-enhancing lesions for the last 2 years, that might give us more information about the neuroprotective qualities of Sapana. Okay, moving on to the next study that I wanted to highlight. This study focuses on treatment effect in progressive MS, and is it possible that there is a therapeutic lag? So what the authors hypothesized was that it's true that all of our studies to date essentially have shown minimal benefit of our anti-inflammatory therapies in progressive MS. But those studies are usually 1 to 2 years long, so they're fairly short relative to the disease duration of MS. And is it possible that, that an effect might come out later on when patients are on these disease-modifying therapies? So what they did was a post hoc analysis on 6-year extension data from the SPECTRIMS secondary progressive MS study using subcutaneous interferon beta 1A, and as well as the 3-year follow-up data from the PROMISE study, which was of glatiramer acetate in primary progressive MS. And they used a stepwise procedure in their Cox models to try to determine at what point would be the best time to look for a delayed treatment effect. And what their models indicated were that for the SPECTRUM study, it was around 2.5 years, and for the PROMISE study, it was around 2 years. And interestingly, if you looked for the treatment effect starting at 2.5 years in SPECTRUMS instead of from the beginning, the hazard ratio for 3-month confirmed disability progression was reduced 35%, and that was significant. And in the PROMISE study, if you looked around 2 years, the hazard ratio for confirmed disability was 0.65, also a 35% reduction, suggesting that there might, in fact, have been a delayed treatment effect. So it's interesting, although secondary progressive MS pathology is thought to be largely neurodegenerative, or progressive MS in general really is thought to be neurodegenerative, it is difficult to distinguish progressive MS from relapsing MS pathologically because there still are inflammatory changes in progressive MS. So it does seem plausible that some benefit from anti-inflammatories might be seen, and that it might take longer for that benefit to kick in because of the greater underlying damage to the central nervous system. Obviously, though, this is a post hoc analysis in which they were kind of moving the time point around to look for a time when the treatment would have been likely to be effective. So this is by no means definitive, but it might lay the groundwork for longer studies in progressive MS for our disease-modifying therapies. The next abstract that I wanted to highlight is called Multiple Sclerosis Broke My Heart, which was an interesting case series about Takotsubo cardiomyopathy, which is a reversible left ventricular dysfunction, which is also called stress-induced cardiomyopathy or broken heart syndrome, because it does sometimes seem to occur in individuals at times of severe emotional distress. The authors found 5 cases of patients with transient left ventricular dysfunction who had MS through the European database for MS. And in these 5 patients, 4 of them, the neurologic signs preceded the cardiac signs by 5 days to 2 weeks, whereas in one patient they were concomitant in onset. And all of these patients did have severe cardiogenic shock and had to be admitted to the ICU. And each patient also had a new lesion in the medulla on MRI. Corticosteroids were used to treat them, and all patients had rapid neurological and cardiac improvement with steroid treatment. So I thought this was interesting because it really highlights the fact that while we don't think of MS as affecting the cardiopulmonary system very much, it definitely is possible, especially with brainstem lesions or cervical lesions or maybe even insular lesions. So if you have a young patient with an unexplained cardiomyopathy, neurologic diagnoses like MS should be considered. Takotsubo cardiomyopathy has also been described with other neurologic conditions like subarachnoid hemorrhage, stroke, and seizure. Next, I wanted to highlight this study of dalfampridine and its effects on cognition in MS. So we are all very familiar with dalfampridine's effects on walking in MS, but there's been some thought and a number of studies looking into potential other benefits from dalfampridine in the MS patient. And what the authors of this study did was they did a prospective study of MS patients who were responders to dalfampridine in terms of their walking. So that meant that they had at least a 20% improvement in walking speed after being on dalfampridine for 14 days. These patients had baseline neuropsychological evaluation and then a follow-up evaluation 5 months later. And the testing included the brief neuropsychological battery, the Stroop test, which looks at selective attention and processing speed, the trail making test, which looks at visual attention and task switching, and the digit span test, which looks at working memory. The Beck Depression Inventory was also performed on each of these patients. So they were able to identify 12 patients who had responded with regards to walking, and they were included in the study. They had an average age of 48.8 years and an average improvement in their walking speed of 38%. So they were definitely responders. And in these patients, most of the cognitive tests did trend towards improvement, with several of them showing significant improvement. And there was no change in the Beck Depression Inventory to suggest that there might have been an underlying benefit in depression that could have confounded the cognitive findings. So I think these are definitely interesting results, but there are some questions that remain that the authors didn't really address. For instance, were the improvements actually clinically meaningful, or were they very mild improvements? And is it possible that patients who don't respond in terms of walking might respond with regards to other neurologic domains when treated with dalfampridine, which can't be answered by a study like this because those patients were excluded. And finally, I wanted to end with a retrospective study comparing the efficacy of dimethyl fumarate, which we'll call DMF, and fingolimod, which we'll call FTY. So this study was from Hirsch and colleagues at Cleveland Clinic, and it looked at patients who were starting DMF or FTY either as first-line or second-line agents. And those patients were watched for 12 months. And they had 38 first-line DMF users and 420 second-line DMF users, compared to 17 first-line FTY users and 300 second-line FTY users. And when you do a study like this, there is a high risk of bias, especially indication bias. So the authors tried to overcome that by using a propensity score model in which they used logistic regression to determine a patient's propensity to receive DMF treatment. And that model included several covariates, including demographic factors, factors related to disease history like disease duration, MRI measures like burden of disease on MRI, as well as clinical and patient-reported outcomes. So looking at the first-line discontinuation rates, so patients who were on these agents first-line, 31.6% discontinued DMF and 23.5% discontinued FTY. And if you did a propensity-adjusted hazard ratio for this, that's a 2.12 higher hazard for discontinuing DMF than FTY, and that was significant. And by far the most common reason for discontinuing DMF was intolerance. And intolerance rates were significantly higher in the DMF groups, with the hazard for stopping due to intolerance in the DMF group being 2.38 compared to the FTY group. Looking at second-line discontinuation rates, again, the model favored FTY with a 1.7 hazard ratio risk of discontinuation in the DMF group, but that was a trend. It did not reach significance with a p-value of 0.08. Finally, looking at efficacy measures for the two treatments, first among the patients who were on first-line therapy. So relapses and MRI activity were not significantly different between the groups, although patients on DMF did have a hazard ratio of 2.03 for an earlier relapse, and that was significant with a p-value of 0.04. with regards to the group receiving treatments as a second-line agent, again, relapses and MRI activity were not significantly different between the groups, and earlier relapses were just on the cusp of significance, with the hazard ratio being 1.51 for an earlier relapse in DMF-treated patients compared to FTY-treated patients. So really no differences were seen in the total disease activity between DMF and FTY, but first-line DMF users generally relapsed earlier, and they were also more likely to discontinue treatment and more likely to stop due to tolerability issues, which is certainly important information to keep in mind when choosing a disease-modifying therapy. So that concludes this episode of the Multiple Sclerosis Highlight Series. I'd like to thank you all for listening, and have a good day.